care? Why do we analyze our feces? Why do, nobody likes looking at our feces, right? Nobody wants to like play in poo in the lab. But it really does help us a lot of times in some different diagnoses of things. So we can look at it for ulcers, cancer, dysentery versus diarrhea. We'll get into all of these. We'll break these all down in a few moments. We'll look at malabsorption, things going on in the body where you're not able to absorb the nutrients. Steatorrhea is fat, creatoria is meat fibers, so we'll talk about those in a little bit. The most common fecal test that is ordered is the fecal occult blood, which you guys used to do in basic lab skills, but I don't think they're doing it anymore. So we'll talk about the fecal occult blood a little bit later in here. Routinely recommended for individuals over 40. Now that's actually being replaced. Have you guys all heard of Cologuard from Exact Sciences right here in town? So that they're getting a lot more of these early detection tests.
It's kind of cool how it works.
Yes, it's very cool how it works. So they're getting a lot more of the cancer detection. And then, of course, colonoscopy is what we do, if that is positive, things like that. So digestion process. Here it goes.
The primary functions of the digestive system are the breakdown of food, called digestion, and absorption of nutrients. Digestion begins in the mouth, where the teeth break food into smaller particles during mastication. Salivary glands, located near the oral cavity, secrete saliva, which begins chemical digestion and keeps the food moist. As food is swallowed, the soft palate blocks the upper pharynx to prevent food from entering the nasal cavity, and multiple voluntary muscles in the face, neck, and tongue contract, pushing food particles through the pharynx. The food passes over the epiglottis, which prevents food entry into the respiratory system, and then into the esophagus, which connects the pharynx to the stomach. The one-way movement of the food mass, now called a bolus, is controlled by wave-like involuntary muscle contractions. This movement is known as peristalsis. The bolus now enters the stomach. Folds in the stomach wall, called rugae, allow for expansion as the stomach fills. Stomach cells secrete hydrochloric acid, pepsinogen, and various regulatory hormones that chemically digest the bolus. Muscular contractions in the stomach churn its contents to further break down the bolus and mix it with stomach secretions to form a thick liquid called chyme. Chyme exits the stomach through the pyloric sphincter and enters the small intestine, the major site of nutrient absorption. The small intestine consists of three parts: the duodenum, jejunum, and ileum. Bile from the liver and digestive enzymes from the pancreas empty into the duodenum to aid in digestion. Absorbed nutrients pass from the lumen of the small intestine into blood and lymph. Chyme not absorbed in the small intestine enters the large intestine. As it passes through the cecum and ascending, transverse, descending, and sigmoid colon, water and salts are absorbed and chyme is converted into feces. The rectum stores feces until nervous stimulation initiates the defecation reflex, resulting in elimination through the anal canal.
Okay, quick little overview of what's going on in the intestinal system. Okay, so digestive system, before we break it down into three parts: the upper digestive system, the mouth, the esophagus, and the stomach, the teeth and the salivary glands, and the gastric secretions are there. We're going to get into each of these a little bit more too. The lower digestive is going to be your intestinal, small intestine, and then the other part of the lower digestive is your large intestine. So upper digestion, your teeth. Chew our food, right? We all are aware of that. Next time you eat, think about how much your tongue plays a part in your chewing. You don't realize it until you're paying attention. And you're like, oh my gosh, my tongue is constantly moving. Not just because I'm talking up here, but because I'm moving the food around to get it to where it needs to be chewed. The amylase secretion happening in the saliva glands, that's gonna start the breakdown of the starches. That's the first of the enzymes that's gonna start the breakdown of the food to get us the nutrition. Then it gets into the esophagus. So the esophagus, you can see this little cross section here, and what happens is it moves, and it has this peristalsis like they talked about. And so it pushes the food down into the stomach, but it's very controlled most of the time. Now, some people have esophageal issues where the esophagus doesn't do that and just sits there. Other people have it where it spasms and just like blocks the whole thing off. So there are issues sometimes with esophagus, but in a normal, healthy human being, most people, you get this peristalsis that's going to help us get the food down the esophagus into the stomach. When we get to the stomach is coated in mucus cells. There's thick and thin mucus in the stomach. The thick mucus is what's going to protect the stomach lining. The pH of the stomach, remember we talked about pH of urine and stuff? The pH of the stomach is about 2. That's really acidic. So the stomach is a mucus membrane. So what happens is if we don't get that coating over the stomach, I mean, think of what happens if we put a pH of 2 something in our mouth or our nose, right? I mean, it's going to destroy it. So this thick mucus is going to help protect the stomach lining at that pH of 2. Then there's a thin, watery mucus, and that gives us substrate. Because if I just eat food and that food sits in my stomach, it's not going to break down. It needs to mix with something, right? Think about using a blender. If I put some food in a blender, but I don't add a liquid piece to it, it's going to get chunky and thick. It's not going to thin out. So that watery mucus is going to help us thin it out so that we can utilize the actual nutrients in that food. The chief cells are cells that are going to secrete the pepsinogen. This is going to be, again, our second of the enzymes. We're not going to memorize all these enzymes down. You'll get that in Bow's class next year. But the pepsinogen will be like the second one that starts the breakdown in the stomach. So we got the starches in the mouth with the saliva, and then you get the pepsin for digesting your proteins into your polypeptides. So that all starts in the stomach then. Then we get into the small intestine and the lower intestine. Do not memorize all this for me. We do not have to have all the different parts memorized. You have to know small intestine and large intestine and what they do. So in the small intestine, it's where the nutrients are going to come into the body from the food. So we've broken it down, we started adding the enzymes, and it gets in that small intestines. And you guys know, we have like a lot of small intestines in there, right? And during that time, as it's working its way through the small intestines, we're absorbing the nutrients into our body from whatever foods we're eating. The small intestines are made. So if this is my small intestine, we have lots of surface area. And if I were to blow up this like area, what we're looking at is, oops, if I were to blow it up, each area has there's lots of surface area throughout the stomach. So we build it, I'm trying to figure out the better way of doing it. So when we build it, we got this, so you got this piece. Well, this is not a good marker either. We need new markers up here. There we go. So there is that piece there, but within this, I've got this, and if I take that out, even within it then, I've got even more. So the idea is it's got the plica, the villi, and the microvilli. So the plica, the villi, and the microvilli. The idea is it's so small, so it's not smooth. It's not just one flat surface. It's lots of surface area. And that surface area is where our nutrients then get absorbed into the body. Again, some duodenum, jejunum, and ileum are parts of the small intestines. In the small intestine, there's going to be all sorts of things secreted, mucus, pepsinase, sucralase, maltase, lactase, lipase, and organidase. All these different enzymes that are going to be breaking down all the different parts of food. Because we know that food has lots of parts, right? Any nutrition label is going to show you how much protein and carbohydrates and this and that and all of that stuff. And all of that has to get broken down. If you're eating things that can't be broken down in the body, they're going to come out the same way that they go in, and you're not going to get any nutrition from them. So it's really important these enzymes all work. I thought I saw a hand. No, okay. And once it gets to the large intestine, in the large intestine, once it's there, no more digestion is occurring, no more absorption at this point of the nutrients, but instead the body starts reabsorbing the water. It starts bringing that water back into the system because remember, just like urine, everything going in, we don't want it all going out or we're gonna be in trouble. We've probably all been that way when you get kind of a GI bug of some sort and you get real dehydrated because you're losing too much water. So the job of the large intestine is to like reabsorb the waters and the salts and help get those back to the body. And then to the final part of the large intestine, elimination of the feces. So we talked saliva has the amylase for starch breakdown. Other organs, the liver. We talked about the liver in urinalysis a few weeks ago. We talked about bilirubin and urobilinogen. So we get the bile, turns to bile salts, which is going to emulsify your fats. Your pancreas has lots of enzymes, and they're going to help break down these guys, the sugars, the fats, proteins, and nucleic acid. So if you remember from that video, the pancreas, the bile duct, and the liver, that's the common bile duct, the gallbladder, I'm sorry, the gallbladder, the liver, and the pancreas secretes in the common bile duct all those different enzymes into the intestines. So that's why these guys are also so important in the digestion of food. Some words, digestion breakdown, so like carbohydrates are going to break down to disaccharides to monosaccharides, proteins break down to peptides to amino acids, fats, emulsified fats, monoglycerides, and free fatty acids. So they start as these whole products, and in that small intestine as they're going through, they're going to be broken down into smaller, usable byproducts for the body. Because the body cannot use a carbohydrate as a carbohydrate, right? We need to break it down into the sugars so our cells can use those sugars to metabolize and to function and to live. So it's really important that our body has all these enzymes to constantly be breaking down the foods to give us nutrition. So fecal formation, 900 mils of fluid enter the GI tract daily, or 9,000, excuse me, 9,000 milliliters of fluid enters the GI tract daily. 5 to 1,500 mils enters the large intestine, and 1,500 mils per day on average of fluid exits the GI system. So it's really important that we get that reabsorption of all that fluid from that large intestine, right? We could be dehydrated really fast. You can see how easy it would be dehydrated in a situation where you have something like a flu bug. I hate the word flu bug. It's a misnomer, right? Because we all know flu is respiratory, but we call the GI bugs flu bugs also. But it's those GI bugs, the noroviruses, things like that. It's really, really easy to become dehydrated really, really quickly with something like that. Takes about 3 days for food to get through the entire digestive system. I've always wondered about this fact though, because anybody else think corn gets through a lot faster? Right? But that's how I test like how fast my system's working. What?
Fruit.
Or what?
Fruit.
Fruit? Yeah, those things that we can't digest. Yeah, we kind of know. It's like, wait a minute.
Something that's never made sense to me though is like if you eat something that you know like I don't know like makes your stomach flare up or like makes you sick or whatever, it seems to like to go faster or like because if something that you ate a couple days ago is like fine and dandy down there, but you eat something and get an upset stomach, like was it something you ate 3 days ago that made your stomach upset and like gave you diarrhea or like is it?
I think it depends on the person because like people with certain issues like dairy, their digestive systems will like get this out of the body fast, and so I think things move a lot faster.
Okay.
For people with those GI systems, do you know more about that? I just know that sometimes it works a lot faster if I eat foods I shouldn't eat.
Because I feel like sometimes I've had instances where I ate something and I feel like my body is automatically rejecting it and I'm like in the bathroom.
Yeah.
Yeah. And so
Fried food and milk both do it for me. So,
I was just gonna say.
so yeah, I think your body just knows.
Missing a gallbladder, have idea. Like, you know, so it's like, how does that work? Does it really take 3 days or like?
Yeah.
Okay.
So yeah, but the book says 3 days.
Okay.
And the large intestine alone is supposed to take 18 to 24 hours. Sure, right, yeah. A few intimate facts. We end up stool 100 to 300 grams per 24 hours is what we end up losing. When you're looking at stool, 70% of our stool, this is a normal, healthy stool, okay? I'm putting that into quotes because some people don't have normal stools. Their normal stool is different, but a normal stool is 70% water. And then it's bacteria and like bacterial debris. There's a lot, did I tell you guys about the gram stain of the stool? Okay, how I really wanted a big canvas of a gram stain of stool for my wall, because it's so pretty, and I can always just say, look at that piece of crap. But that bacteria is gorgeous, but it takes up a huge amount of your stool. Undigested material, vegetable fibers, corn, I always laugh, we all love, anybody here not like corn? Yeah, I love corn, and it's like the most useless, my husband insists it's a vegetable, I'm like, no, it is not a vegetable. It is a useless thing that goes into your mouth, but it's yummy.
It's a seed. Seeds don't digest for obvious reasons, right? And so it's supposed to continue to grow the corn. So seeds don't digest.
It's a waste, but it's so good. It does not count as a vegetable though.
Is it a fiber?
I think it actually does count as a fiber, because the psyllium husk, it just comes out the same way it goes in, because you can take that Metamucil, which is like psyllium husk, and I know it's not husk, but I think it does work to like scrape the insides of your intestines and,
Yeah,
you
I
know.
had that to nurses when I took nutrition for animals. They're like, corn is great fiber, so, yeah.
So no nutrition but good fiber. Okay, good. See, there's something good about eating corn, other than the yummy butter and everything else that comes with it. Epithelial cells, remember we've talked about epithelial cells, right? Every lining in our body is full of epithelial cells, so that's in stool. Some amount of electrolytes, more so if you're sick, right? You gotta be careful of that. And then gastrointestinal secretions, and then small amounts of fat, like 4 to 6%, very small amounts of fat. Most fat does not come out. Most of our fat gets utilized throughout the body. Okay, and then we already talked about that. More information about fecal formation. We're gonna talk about diarrhea versus constipation. When you're looking at these things, there's a great video I'm gonna show here at the end that talks about constipation and what happens with normal versus constipation. Depends on the volume of fluid, movement of the feces, how fast it's moving, how slow it's moving, what's going on, and then inhibition of water absorption. So how well is your large intestine reabsorbing the water? Things like cholera inhibit water absorption. And if you remember, cholera is also known as rice water stools, because what happens, your body can't reabsorb that water because it's trying to flush out the bacteria, and the cholera prevents that reabsorption. And because of that, people that end up with cholera end up oftentimes dying of dehydration. They just lose too much fluid over time. This is why when you do get, really, really bad cases of food poisoning and things like that, it can land you in the hospital because of fluid loss. Diarrhea versus dysentery. There's 3 different types of diarrhea we're going to talk about. The secretory diarrhea, like infection and enterotoxin-producing microorganisms. That's going to be your E. coli and your Vibrio. You could possibly lose up to 21 liters of water, of fluid, in 24 hours. You can't stay hydrated enough when you have something like that. E. coli 0157H7 produces like a bloody diarrhea. It's an enterotoxic, so it actually makes like this really crazy bloody diarrhea. You will get more information on this in microbiology. I don't know if you've had general micro, if they covered the specific types of GI bugs a little bit. Okay. Okay. So then this hypovolemic shock can occur when you're losing this much fluid, 21 liters of stool in 24 hours. You can end up with hypovolemic shock. Hypo, low, volemic volume, because you're losing all that fluid.
With cholera, if you can actually stay hydrated, it's a self-limiting thing.
Right. But it's the same hydrated piece that's really, really hard. And they don't like treating certain bacteria, because if they treat it,
It becomes antibiotic resistant.
and it takes longer to remove because the body's trying to remove it. And they're all, Salmonella, Shigella, all these things are supposed to be self-limiting. But you gotta stay hydrated during the time. And if you're losing too much fluids, you have to also watch for other electrolyte imbalances that can cause major issues. Last August, I was actually hospitalized for 3 days with salmonella. My potassium dropped so low, my electrolyte balance got so bad, my potassium was critical, and they were trying to prevent a cardiac arrest because it was so bad. I have to laugh. No one gets hospitalized for salmonella. I got hospitalized for salmonella. I went in for hydration. I knew I was getting too dehydrated. You got too far and you can't recover. And they're like, yeah, you just bought a bed. And it took 3 days because they didn't want to treat salmonella, right? Because they wanted it to flush through, and it was this balance. It was crazy. I have a whole thing as a case study. It's amazing. I shouldn't say amazing, but I mean, it really is fascinating. I'm a dork. I have my own case studies at home. Second one, osmotic diarrhea, maldigestion and malabsorption. Whoops. And then diarrhea due to intestinal hypermobility. So if you deal with something like irritable bowel, I'd come up with the word of it, and so what happens is you get this intestinal hypermobility, high amounts of, it just goes, right? It's not normal. It's not like it's nice and slow. It's like, it's gonna push things through. So diarrhea versus dysentery, ways to differentiate. Presence of white cells. Regular diarrhea, there will be no white cells. Dysentery, you're gonna see white cells. Presence of red cells. Diarrhea, no. Dysentery, possibly, depending on what's going on. Abdominal symptoms, bloating versus cramping. I don't know about you, but these two things are very similar. How are you really gonna know, right? And what I might call bloating, somebody else might call cramping. So I don't like differentiating my abdominal symptoms. Amounts of stool, diarrhea, large amounts of stool. Dysentery tends to be a little more normal. And appearance, liquid versus soft with pus present. They're both gonna be pretty liquid. You're not gonna be really able to differentiate them in a toilet. You actually have to look in a collection container to differentiate that. So now the fun part, collection, right? Patient education issues. Just like that 24-hour urine, how many people are gonna be really excited to collect a stool at home? No one, right? So it's really important to make sure to educate the patients on how important this is, the steps involved, what's involved. Oftentimes, the patients don't really have a lot of control, right? You can't, it's really easy. You go to the doctor to collect a urine. Almost everybody within an hour can give a urine sample. Stool, probably not so much, right? So you have to wait till the body's ready. It's very undesirable to the patients. You start talking about stool collection and everybody goes running the other way. It's like parts of our job that we're not allowed to talk about at the dinner table. This is one of them. And so it's really important, just like the 24-hour collection, to do written and verbal instructions. So you're gonna tell them the instructions, but let me tell you, you're gonna be talking to them and they're gonna be going, oh my God, I have to do what, oh my God, I don't want you to do, I have to type that, I have to, right? They're not listening. They may hear 1 out of every 10 words you say. They're not really listening. So it's really important to give written, clear directions also, so that when their brain calms down, they can actually read what needs to be done. Because depending on what you're collecting the stool for, there's different processes for different things. Specimen containers must be clean, non-breakable, sealable, and leak-proof, right? We all know how that works. 72-hour specimens have to be, they get done in clean paint cans. They're literally clean paint cans that they send home with you. Depending on what you're doing, depends on how much you have to collect. Certain things have dietary restrictions, what you should and shouldn't eat before you do them, because they can interfere. The occult blood, you're not supposed to eat a lot of vitamin C because it can interfere. Go figure, ascorbic acid interferes with something, right? Hopefully that's making a lot more sense now we've gone through all these urine tests. We want the 72-hour quantitative fecal fat. So yes, you collect all your stool for 72 hours. Gas starts forming because of the bacteria in it, and so you have to be careful of exploding cans. We'll talk about that in one of the next slides. Things to avoid: urine. Depending on what you're looking for, urine can destroy. If you're looking for ova and parasites, urine can destroy the shells of the little eggs you're looking for, and so any amount of urine in a stool contamination is going to cause problems. Urine can actually kill some of the bacteria we're looking for in the stool if you're looking for certain bacteria. Toilet paper. We don't want toilet paper in the collection. Toilet water. Do not go scooping it from the toilet. What else? Cleaning agents. Especially for O&P, but you guys have learned how many cleaning agents interfere with testing also. So it's really important that we collect this in a hat and put it into the stool container, and we don't try to collect it other ways. Sorry, I forgot that made that noise. Yeah, want to go out for these exploding cans. Because if they put the lid on nice and tight and you go and open them, the lids can go flying and stool can go flying. We also put it into a shaker, depending on the tests, and that can cause problems. So you want to be aware. And if you see a paint can, be aware. Don't put your face in front of it when you're opening it. So macroscopic examination, normal color is kind of shades of brown. If you remember from the Billy Rubin lecture in urinalysis, It's because the conjugated bilirubin gets into the stool, goes to urobilinogen, goes to urobilin. That's the normal color of our stool. That's what makes it that brown color. However, there are abnormal colors for a variety of reasons. Clay colored, pale yellow, white, or gray, bile duct obstruction. We talked about that when we talked about our bilirubin in our urine. Black, when you're dealing with black, you're dealing with upper gastrointestinal bleeding. If it's upper gastrointestinal, blood over time turns darker as it takes time to go through the system. Remember, urinary tract infections, it's darker usually blood than lower, upper urinary versus lower. Also though, iron therapy and bismuth therapy, Pepto-Bismol. Nobody warns you about this. And the first time your child ends up with a black stool after you've been through this program and your paranoia jumps to upper gastrointestinal bleed, Pepto-Bismol turns your stool black. Okay? Take it from a panicked parent who had to chart the doctor. Red, lower gastrointestinal bleeding. So upper, because it gets older, turns black. Lower, it's red. However, food dyes also can cause this. A good friend of mine, his mom was known for having these GI bleeds. And he was up in Oshkosh, and she was down here, and she went to the hospital. So he gets the call. He's the primary family member. So he's flying down to the hospital. She gets here, and they're like, everything's negative. Well, her stool was red. They could see it. She'd eaten a big piece of red velvet cake the night before. And it was the red velvet cake that turned her stool red. So think about what you're eating. And then certain other food drugs can change the colors of stool. Green vegetables, such as spinach, biliverdin formation, and certain antibiotics. A lot of antibiotics can really mess with your GI system, and a lot of your stools will turn green. Yellow, rhubarb. If you eat a lot of rhubarb, I don't know how much you'd have to eat to turn your stool yellow, but a lot of rhubarb can do that. So consistency and form. Normal consistency, cylindrical masses, right? That's normal stool. We're used to seeing, pictures of the stools and stuff like that. Abnormal, watery stools is seen in diarrhea. Small, hard masses, you see that signs in constipation. Long ribbon-like stools, possible obstructions. So you've got, some constipation that's led to obstruction. So the stool that gets by, it kind of like squeezes by in the intestine and becomes this like long ribbon-like. And then very mucousy, possible inflammation of the intestinal walls should be noted. If it's real mucousy, you want to make sure to note that in the lab. Odor. Anybody here volunteering to walk the stool? No. Primarily due to the anaerobic bacteria creates the odor of a normal stool. We do not open up stool and smell it, just like we don't intentionally open it up and smell our urines, but when you open it like a urine, you do smell it by side, just as a side note. Stools usually get done under the cabinet because nobody wants that smell in the lab. We don't have windows to air out the lab, so usually stools get done under a cabinet. Now, microscopically, usually you take a small aliquot of the stool, and you're going to look at it. Types of tests we do, we can look for fecal leukocytes and mucus. We will be looking at fecal leukocytes tomorrow in lab, so make sure to do that reading so you know kind of what you're looking at. I'll have a couple scopes of positives and negatives, and then I'll have an unknown that you'll need to look at. We can look for fecal fat, which is the steatorrhea. We're going to be looking for fecal fat. Meat fibers, creatoria, and then parasites. Usually this gets done in microbiology, but there are special parasite tests that we can look for eggs. Usually we look for the eggs. So fecal leukocytes, when we see fecal leukocytes, it means there's something infective going on. That makes sense, right? Anytime we see white blood cells and we see the leukocytes, it means there's some sort of infection happening. So when we do a stool, we're going to smear it on a stain, and we're going to do a white stain, or a methylene blue stain, or a gram stain, depending on your facility. Everybody's facility has slightly different instructions of how they do it. Diseases with fecal leukocytes present include the ulcerative colitis, so ulcers, Yersinia, Clostridium difficile, what other ones? Shigella, Campylobacter, Salmonella, all of those are going to have fecal leukocytes, and amoebic dysentery. So this Entamoeba histolyticus is a parasite. It's a small little egg that we see sometimes in stools. Now, diseases without leukocytes, viral gastroenteritis, norovirus. When you get the norovirus stuff, it's not going to have fecal leukocytes. Malabsorption diarrhea, if there's from some reason that your body is unable to absorb the nutrients out of the food, you're gonna end up with diarrhea type symptoms, but they won't have the leukocytes. And then bacterial enterotoxin diarrhea, such as introductic E. coli, Vibrio cholera, Bacillus cereus, Staph aureus, any of those will not have fecal leukocytes. Anytime you have inflammatory conditions, you're gonna have mucus. So we often see mucus with these. So what we do for the fecal leukocytes, emulsify the stool. So we're gonna mix it, right? We're gonna make sure it's liquid. We can't just smear a solid. We have to like make it liquid to make a thin enough prep. We're gonna place 2 drops of methylene blue into it. So you put the stain into the emulsified stool and you spread it on a slide and you put a cover slip over it. And then you're gonna examine it for neutrophils under 40x and then confirm white cells on the 100x. Our situation tomorrow, we'll only look at it at 40. You can definitely confirm at 40 the neutrophils in these stains. So this is what it looks like. You actually see all these leukocytes. That's a positive with methylene blue. Diseases with them present, anything that's going to invade the GI mucosa. So these are the things we just talked about. Here is a gram stain of the fecal leukocytes. So again, you can tell they're actual leukocytes floating around there. Direct fecal smear, you're going to note the leukocytes. They're all pink. What else then? Fecal fat, we look at fecal fats. Sudan, oil red, you've seen those? We look for fats in urines. We should see fewer than 60 globules per high power field. Meat fibers, we look for eosinophil and 10% alcohol. So with fat, steatorrhea means increased fat. Normal fecal fat, as I said, is less than 6 grams per day. Anything you have greater than 6 grams that's your definition of steatorrhea. I don't know if I'm saying that right. I've always just said it from reading it. So however you say it in your head works for me. Characteristics, light colored stool, foamy, bulky. So the foamy, because the fats make things kind of foamy and icky. Causes, malabsorption, celiacs, tropical sprue, which is some sort of a disease people get south. I really don't even know what that one is. Maldigestion, pancreatitis, cystic fibrosis, pancreatic cancer. These are all maldigestion issues. So malabsorption, the body can't absorb the nutrients. Maldigesting, we can't digest them. We're missing the enzymes to actually digest the food down. So here is what that fecal fat looks like. It's kind of this like orangish color here when you actually put the stains in it. Orange-red coloration. Quantitative fecal fats, these are the ones that are the 72-hour stools you collect in the paint can. They get special dietary instructions, including make sure to eat plenty of fat. You don't want to like not eat fat because you want to know how well your body's utilizing it, what's going on with it. So you can't like just avoid the fat for those days. No skipped meals, no medications that are going to interfere. They want to make sure they're actually getting a good sample of what's going on. All specimens get collected and then they're weighed and homogenized, meaning we literally put it into a shaker and we homogenize it. We want to mix it. We want the full 72 hours to be one nice mix. We take an aliquot of that and we're going to chemically analyze it looking for fat content. Creatoria is what we're looking for. We're looking for these meat fibers. That's what a meat fiber under 400x looks like. We see this with pancreatic insufficiency, biliary obstruction, and then gastrointestinal fistulas. We take a little bit of stool, we emulsify it with 10% eosin and alcohol, let it stand for 3 minutes, and we count the number of meat fibers per high power field. Pretty straightforward when you're looking for it. They're pretty obvious when you're looking for the meat fibers, what you're looking for. Fecal occult, you guys don't do this in basic lab skills anymore, so this is what these tests look like. There's 2 different sides. The one side says, open this tab with ready to use. So you open this side, it's got 2 squares, and you put little pieces of stool in each one. Just a little mark of it. You don't need a ton. You don't need to put a cup of stool in this tiny little card. These cards are only about 3 by 3, 2 by 3, something like that. And then when you get to the lab, and then actually it's guaiac paper. What's on these slides is guaiac paper. And when it gets to the lab, we open the back side, and the back side has this little performance monitor area. It's our QC. So we put the developer there to make sure that the paper's working. And then we put developer onto each of these squares and look for this like really pretty purple color, which is bad. The pretty purple is bad. but that's what we're looking for. We're looking for whether we're looking for a positive or negative. This is a peroxidase reaction, just like the reaction on the test strips, the urine test strips for blood. Same idea, it's a peroxidase reaction for the color change. And this is what we look for. We're looking for blood in the stool. Occult means hidden. So it's hidden blood. It's not gross. If we see grossly bloody stool, we don't need to do this because there's blood in the stool. If we can see it, if it's grossly bloody, we don't have to do it. But if they're having problems, if they're anemic and we don't know why they're anemic, this is one of the things to check quick. Are they, do they have a GI bleed of some sort that's a milder GI bleed that we're not seeing the gross amount of blood? So this is when we would do this test. So here is the principle, the paper, the guaiac paper plus H2O2, which is peroxide, is going to cause peroxidase activity and turn it to a blue compound. If you ever spill blood on your clothes in the lab, peroxide is a great way of getting the blood because it breaks it down and gets it out of your clothes. So it's always a good idea once you're working in a lab to keep a bottle of peroxide in your cabinet for that. So here's just how it's done. You open the back flap, put a little stool on, flip the other side. You have to let it sit for, there's an amount of time. I don't remember what the time is, so you don't want to put it on and immediately do the back side. Then you flip it over and you put the drops, one drop in the middle for color and then one on each square. This is negative, this is that pretty blue color, purple color, and that's going to be your positive. Fetal hemoglobin, this is going to be the APT test. So when neonates are born and they vomit blood or their stools have blood, we have to decide, is it theirs or is it mom's that was ingested during childbirth? Because we all know childbirth is messy, right? If it's mom's, it's self-limiting, it goes away. But we can't just assume that because babies are tiny and a small bleed, something going on the inside could cause problems really, really fast with a little guy, right? Or a little girl. So what we want to do is find out if it's from their own GI tract or if it's something that was swallowed during birth. So fetal hemoglobin is more resistant to alkalis. And so we take the specimen, we centrifuge the feces, and we aliquot it into 2 tubes. In 1 tube, we add sodium hydroxide, and we look for any color change. Adult hemoglobin will change to a yellow-brown. Fetal hemoglobin will remain pink. So this is how we do this. It's a pretty quick test. A lot of places send it out, which means it's not so quick, right? Anytime you have to send something out, it may not be as quick. But it is important to find out very quickly, as fast as you can, whose blood it is. We already covered this one. Sometimes you can look for fecal carbohydrates with malabsorption issues. So clinical conditions such as lactose intolerance or other hereditary disaccharide deficiencies. So when you're looking at things that are hereditary, we can do fecal pH. Normal is everything greater than 7, abnormal between 5 and 6. We can do a Clinitest, just like the urine Clinitest. We're looking at the same idea. Of course, remember, Clinitest is the Kleenex of facial tissue, right? Where we'll dilute the supernatant and do look for sugars in the stool. We can look for trypsin, which is going to look for pancreatic issues going on. So trypsin is going to tell us if there's trypsin in the stool, we got some pancreatic issues going on. Malabsorption versus maldigestion. So this is just kind of a chart to show like when we'll see maldigestion versus malabsorption issues. And I'm going to share the first video here.
The final stages of food digestion take place in the large intestine, or colon. After nourishment is extracted from what we eat, the leftover waste material mixed with water flows from the small intestine into the colon. After entering the colon, stool loses water as it travels upward through the ascending colon and across the belly through the transverse colon. As water is lost, stool returns from a liquid into a solid as it goes down toward the rectum in the descending colon. Stool is moved through the sections of the colon by waves of squeezing muscles in an action called peristalsis. Constipation can occur if too much water is absorbed from the stool or if peristalsis is slowed down. Many other factors can also play a role, such as a poor diet low in fiber, emotional stress, or other medical conditions.
You can stop
under stress?
Oh. Mm-hmm.
Really? Yeah, I've never heard that before.
Yeah, GI issues, stress can cause GI issues to go either way.
Okay.
Yeah, GI issues are super, especially in kids. Little kids are notorious for getting constipated, like during travel and things like that, just because it's different, it's change, it's a little bit of stress, even though it's a fun stress for them. It's very, very common for littles to become constipated while traveling. Something you want to watch for when you start having them.
Happens to adults too.
Yes, it does, especially adults whose poo knows home.
Yep.
Some people are very, very, very big on poo knows when it's home. And so people who travel really struggle sometimes.
Mainly heard it go the other direction, like I've heard of, like, stress poops. But
Yep. It depends on your body and what happens. So, okay, and this last one is just for fun.
Hey, Miss Miller, we just need a stool sample.
Why do you need a stool sample if you think I'm just a nut?
'Cause the answer's not in your head, my dear, it's in your butt. You see, everything comes down to poo. From the top of your head to the sole of your shoe. We can figure out what's wrong with you by looking at your poo.
Turk? Do you have a hemorrhoid or is it rectal cancer? When you flush your dookie down, you flush away the answer.
It doesn't really matter if it's hard or if it's loose. We'll figure out what's ailing you as long as it's a deuce. Yes! Everything comes down to poo.
Everything comes down to
Cardiovascular and lymphatic, yes, the nervous system too. All across the nation, we trust in defecation. Everything comes down to poo.
If you want to know what's wrong, don't sit and act so cool. Just be a man and eat some bread and drop the kids off at the pool.
My stomach hurts.
Check the poo.
Sprained my ankle.
Check the poo.
I was shot. Check the poo. Homeless guy threw poo in my eye.
Check the poo.
Mine are his. First him, then you. It may sound gross. You may say shush. But we need to see what comes out of your tush. Because everything comes down to poo. Whether it's a tumor or a touch of the flu. Please won't you pinch us off a big fat clue?
Our number one test is your number two.
If there's no